The current interleukin 2 is coming into the clinical application by using high doses of interleukin 2, and that form of administration of interleukin 2 has been traditionally associated with high toxicity and complexity of the administration of this cytokine, since you need to administer it very frequently, every 6 to 8 hours. And the toxicity associated with this form of administration leads to a high complexity of administration in terms of the patient has to be monitored on the intensive care unit because of cardiac arrhythmias, hypotension, and that lead to hypoperfusions of other organs leading to organ dysfunction, as well as a pulmonary edema because the high dose interleukin 2 is associated with another phenomena called leaky vascular syndrome that leads to fluid leakage into the lungs, and that causes and compromises the lung functions. So we always wanted the efficacy of the high dose IL-2 but without the toxicity. Having a cytokine like NKTR-214, which is a pegylated cytokine, and the prodrug design of that cytokines allow for two advantages. One is in terms of toxicity. The slow release of the pegylations allow for activation of the immune system, but without the reactive compensatory mechanisms that lead to spike of proliferation of the immune cells very quickly and lead to the associated side effects that we just described right now. But also the drug designs allow for a biased binding to the beta and gamma subunits of the IL-2 receptor without binding to the alpha subunit. Binding to the alpha subunit is lead to activation of endothelial cells in the pulmonary vasculature, and that leads to the leaky vascular syndromes and clinically to development of pulmonary edema, which leads to complications. So in terms of toxicity, also the pegylated cytokines 1 lead to slow but sustained release of the cytokine that prevents some of the toxicities, and also the biased binding into the beta and gamma subunits of the IL-2 receptor and prevention from the IL-2 alpha subunit of the receptor decreases the pulmonary edema associated with the high dose cytokine IL-2. In terms of efficacy, the beta gamma subunit activations without the alpha subunit activations lead to preferential expansions of the effector T cells and the natural killers in the tumor microenvironment, but without the expansion of the T regulatory cells, which depends a lot on their alpha subunit binding of the IL-2. And that's a clear advantage for the cytokine over the traditional high dose IL-2 because it really leads to high ratio of CD8 to Treg in the tumor microenvironment where the T cell presence make most difference.